started your timer and here is your question. Yes. Right. So if you have read and understood, considering your surgical pathology patient, kindly tell me what is your differential diagnosis for this patient?
Yes, ma'am. This patient probably is having renal osteodystrophy secondary to a chronic renal failure,
Okay.
as there is a low level of vitamin D and activated vitamin D and high level of parathyroid hormone.
So what are the differential diagnoses, 3 to 4, if you can tell me in one breath, that you're going to consider?
It could be a primary hyperparathyroidism.
Okay.
And it could be a familial hyperphosphatemia.
Okay.
I'm sorry, ma'am, I'm not able to answer this question.
All right. Can you, if you have read and according to your understanding, what is the pathogenesis or pathophysiology, which you think is behind all this patient's condition?
Considering this patient has chronic renal failure and he is having a young age, the possible cause could be a polycystic kidney disease.
Okay.
I would like to examine the patient to further confirm my diagnosis as well. And in this disease, there is formation of multiple.
Yes. That was my next question.
Yes,
if you consider it to be polycystic kidney disease in an adult, so what is the gross pathology that you expect to find?
Yes, the kidney is distorted and deformed, and there are formation of multiple large cysts that are compressing the normal structure and causing the insufficiency of renal functions.
What is the mode of inheritance?
This is the gross pathology.
Yes, that's the gross pathology. So what is the mode of inheritance of this
autosomal
condition?
dominant.
Yes. Which are the genes which are involved?
It's a disease. Yeah, these are PKD1 and PKD2 that are involved in autosomal dominant pattern.
All right. Okay. Now, if you can consider this condition, and now tell me that what is the pathogenesis behind the formation of the cyst?
Yes, actually, the polycystin gene is involved. That is the protein is involved, and there is abnormality of calcium regulation as well as
but how the
cellular
cysts
growth
are
functions.
Formed? Yes.
That causes. Yeah. There is increased multiplication of tubular epithelial cells that first cause a bulge. Yes. And gradually, the passage of time, they form circulations, and ultimately, they are isolated cysts. And these cysts enlarge because of cellular proliferation and transepithelial fluid accumulation. And finally, the cyst enlarge in size, compress the normal kidney tissue.
How does it come across and leaves an isolated cyst?
Sorry, ma'am?
How this condition comes across and leaves one isolated cyst?
Usually there are polycystic kidney disease. There are multiple cysts. One diagnosis is simple cyst that could be a differential cyst. If there is blockage of the tubular duct system, then it will cause an isolated cyst. But in this case, there are multiple cysts.
Can you name few other organs which are also or which can also have cyst formation?
Yes, liver, spleen, and pancreas and ovaries. These are other organs that can have cysts in this condition.
Can you name few complications that can occur as a result of cyst formation?
In case of brain, it can cause perianeurysm that can rupture and cause subarachnoid hemorrhage. And in case of liver, it can cause pressure symptoms due to cyst formation, causing common bile duct obstruction and jaundice. Similarly, in pancreas, it can cause chronic pancreatitis because of cyst formations.
Okay.
And in kidney, it can cause renal failure and hematuria in kidney itself.
All right. Considering this, this is polycystic kidney disease in an adult. How would that differ from polycystic kidney disease in a child?
There is a mass formation, and I think one differential is von Hippel-Lindau disease that could cause polycystic kidney in children as well. And I'm not able to answer this question. I'm sorry.
Okay, can you please tell me why a patient with polycystic kidney disease presents with pain?
Pain is because of stretching of renal capsule as well as stretch on the renal pedicle. These are the two reasons why it's caused pain. And also, as the size of kidney enlarges, it will cause pressure symptoms on other organs as
well. Can you please tell me what other symptoms would there be present other than pain?
Yes. Apart from pain, there will be mass in the flank and there will be hematuria. And once the patient has advanced disease, then there will be signs of renal failure.
Okay. Right. Can you please tell me what are the, now if you would have to think, if a patient has polycystic kidney disease as an adult, where would you suspect another pathology to occur or to be present?
Yes, most serious will be the perianeurysm in brain that could rupture and cause subarachnoid hemorrhage, can be lethal. And then there are other cyst formation in the other viscera as well that we need to suspect and look for.
If you have to do the differential diagnosis of cystic condition, so what are the differentials that you'll consider? If you can tell now.
Yes, the first will be simple cyst, von Hippel-Lindau disease, and medullary sponge kidneys.
And even tuberculosis, tuberous sclerosis.
Yes, tuberous sclerosis. Yes, this
what should be the treatment alternative or options that you can offer to the patient?
Patient will require hemodialysis for the worsening condition, and a renal transplant will be necessary in advanced stage.
All right. Why should a patient undergo?
For other
Yes, please.
For other stigmata like renal osteodystrophy, they will require supportive treatment like activated vitamin D supplements and erythropoietin for anemia. These are supportive measures.
Okay. Can you please tell me why this patient has increased levels of FGF23? What type of tumor marker, or what is it? What does it signify?
It could be fibroblast growth factor, yes. And it might signify development of malignancy in the kidney. I'm not sure. I will not continue with this answer because I'm not sure.
All right. All right. Okay. Can you tell me, you said a patient would need hemodialysis and even renal transplant. So what are the things that you'll consider if patient has to undergo for the transplant? Renal transplant.
Patient will require matching, that is the ABO blood type as well as HLA-DR matching to avoid any unexpected graft rejections.
Out of HLA matching, which one is more important?
Yes, HLA-A, B, and HLA-DR are the most important.
All right. Can you tell me quickly, Belezgon, what are the types of rejections that you expect if patient has undergone renal transplant?
Yes. Within minutes to hour, it's hyperacute rejection due to preformed antibiotics. Then acute rejection can occur within a week to 100 days. That is 3 months, and chronic rejection occurs up to a period of 5 years or more.
Can you define hyperacute rejection?
Hyperacute rejection is because of preformed antibodies, and it causes hemolysis hemorrhage and thrombosis within the vessels, and it causes a swollen mottled kidney that needs to be removed in order to avoid any infection.
Okay, good. All right, when a patient undergoes renal transplant, what else is more important to consider?
There are many things which are important usually.
Once you're
we need to, apart from tissue typing and yes, they will require immunosuppression therapy for a long-term period. And this will include corticosteroids as well as other immunomodulators.
So what is more important for you to observe as a physician or as a
we need to observe the patient for any signs of graft rejection like oliguria or tenderness.
No.
And we need to start early high dose.
Patient with immunosuppression are more likely to have malignancy, so you have to watch out.
More likely
what type
to,
of
yes, they are.
What are the types? What are the most common malignancies that occur in patients with immunosuppression?
A patient can have lymphomas, leukemias, and skin cell cancers like squamous cell carcinoma or squamous cell carcinoma cervix or basal cell carcinoma. Yes. These are the most common malignancy. Or Kaposi sarcoma is also common in immunocompromised patients.
So if there is graft rejection, what is the management? Ultimate management?
In case of graft rejections, patient has to be prescribed high dose of IV prednisolone and following that pathology.
First of all, you'll remove the graft and then you'll take care of it. Even if a patient who develops carcinoma malignancy, even in that condition, you would have to remove the graft and then go ahead with the chemotherapy. Okay, thank you. Can you, describe what you're looking at? I'm sorry, I didn't know I had a picture.
Yes, this is a specimen of polycystic kidney disease specimen, and it shows that there are multiple.
It's a picture of a specimen. Yes. What can you see?
Yes, it's a
image or
picture of polycystic kidney disease.
So what
that is showing the distorted kidney with multiple cysts formation.
Is it distorted or shrunken?
Yes, we can see multiple cysts of different sizes.
Yes. Is it
distorted and enlarged?
Shrunken. Distorted and shrunken. Okay. So you can see.
Sorry, ma'am, there is no scale. Yeah, there is a scale on
there is a scale here.
Yes,
which
a scale.
shows you, but then you can see. Yes. Okay, it's.
Yes.
All right. Good. Thank you.
Yes, ma'am.
Here is your question.
Ma'am, this is for hernia, I think.
It's not, I'm sorry. I gave you wrong one. Yes. You want to continue or you want to change?
No problem, ma'am.
Here is your question. qualified. So if you're read and understood, considering the history taking session, kindly begin.
Hello, my name is Dr. Saddam Hussain. I am the one of the exam candidates. May I confirm your name and age, please?
My name is Mr. Downey, 56 years.
Nice to meet you, Downey. Today I have been asked to ask you a few questions regarding your. Are you okay with this?
Yes.
How may I help you today?
Doctor, I noticed that I have blood in my urine. I've had it for about 4-5 weeks now. And I also have this pain on the left side for about 2 days as well. My blood in the urine has been on for 5 weeks.
Oh, I'm so sorry to hear that. Can you please tell me a little bit more about when did you first notice this?
I started noticing it about 5 weeks ago when I wanted to urinate.
Okay. You noticed during the passing of urine that?
Yes, I noticed that I was passing urine. I was passing blood in urine when I wanted to urinate.
Okay. Is there any other place from the bleeding occurs, like from your nose or from your mouth?
No, there's no other bleeding from any place. It's just the blood in the urine.
Okay. Okay. Have you recently in beetroot?
No, doc.
Okay. How the urine, the urine is coming? At the start or end or throughout your urination process?
Yeah, the blood in urine is totally mixed with the urine. It starts whenever I start urinating, the blood starts with the urination. It's totally mixed with the urine.
So sorry to hear that. Do you pass any clots during urination?
No, yes, I passed a clot or something that looks fleshy that I've passed in the urine.
Okay, can you please identify where the exact site of pain, as you earlier mentioned that you have also pain as well?
Sorry, doc.
I'm asking about the pain.
Okay, yes.
Can you identify the exact location of your pain?
Yes, I noticed the pain on the left side of left lower loin pain on the left side of my abdomen. The pain has been dull, a very dull pain.
Oh, it must you understand. Can you classify, describe the pain? Either it's which character? Either it's a dull pain or sorry. You mentioned that it's a dull pain. Does this pain radiate toward any other area?
Yes, it radiates toward my lower abdomen. It radiates toward my lower abdomen.
Okay. Can you please classify your pain if it is be grade from 1 to 10? 10 is the most severe pain. So how you will rate your pain?
Okay, my pain is 6. I'll give it a 6.
6 out of 10. Okay.
Yes.
Decreasing or increasing?
When I move or when I do activities, when I walk, the pain increases, but when I rest, the pain reduces.
Is there any specific time during which the pain is increases? Are you experiencing all the days?
Yes, it just comes and goes on its own. There's no specific time.
Do you have a fever associated with this pain and hematuria?
No, there is no fever. I don't have any fever.
Okay. How's your appetite?
Well, my appetite has been poor.
Okay. Is there any unintentional weight loss you have noticed?
Yes, I noticed that I've been losing weight, doctor.
Can you tell me please a little bit more? How many kilos for how long?
Okay, I noticed that my clothes don't fit me very well. My clothes that I used to wear, they don't fit me very well again. They are loose now.
Okay. Does this pain is radiated towards your back? Have you ever noticed that you have a back pain as well?
Come again. Sorry, doctor, I couldn't hear you.
I'm asking you, do you have a back pain as well?
Yes, I have a waist pain as well.
Okay. Any recently trauma or anything else?
No, I never experienced any trauma.
Okay.
All right.
How often do you get up at night to pass urine?
Can you summarize your history now, please?
Yes, sir. 50-year-old male factory worker is complaining of painless blood in the urine for last 5 weeks, and he is also pain at the ground lower region for last 5 days. So my top differential diagnosis would be CA bladder,
okay,
CA kidney, and then kidney stones or any infection like a pyelonephritis.
What investigations would you ask for to confirm your diagnosis?
After taking history, I will do clinical examination along with the digital examination to rule out any hyperplasia or growth of the prostate, and then I will go for the full blood count, urine electrolyte, and clotting screen, and I will do urine deficit test to confirm the hematuria. And for assess of the infection, as I already have done this, so I will take WBC count, and I will take urine sample for cytology as well. And for CA bladder, I will go for some non-investigation like CT scan to confirm my diagnosis.
What are the treatment options that you can offer to the patient?
Ma'am, depend on the stage of the CA. If it confirmed it's the CA bladder, then either it's resectable or irresectable. If it's resectable, so I will do T or BT or radical hysterectomy. If it is not resectable, so I will go for chemo, radiotherapy, and immunotherapy, like intravesical BCG as well.
Okay. Right, your time is over. Thank you. So, yes, can you first give feedback to Dr. Saddam since you were helping? Yes, Dr.
Good evening, can I say?
Yes, please.
Can I say something? I think, I think there were some parts that he missed when he was taking the history.
Okay.
For example, he didn't ask me if my abdomen was swelling, if I had any swelling in the abdomen, which can also rule out an intra-abdominal mass in those questions.
Yes.
Then he didn't ask me my occupation, what I did for a living, if I smoked.
So basically, you tell the names of the topics which you missed, like your social history, your family history, maybe your medical and surgical history, your drug history, and ICE, idea, concern, and
then he also,
expectation, and systemic review.
And then he also didn't. He also missed. He didn't ask me of chronic cough or contact with patient with chronic cough to rule out renal tuberculosis.
Okay.
Which can also be a differential. Well, I think maybe towards the end of the presentation, that was when he remembered the lower urinary tract symptom,
Yes.
they should have
Yes.
asked earlier.
Yes.
Things like frequency urges, he remembered that, but it was time that caught him out.
Yes.
But aside that, I think he did well.
Yes, when we give feedback, so this last sentence that you said, we said first that he did very well, and we thank them because we got the opportunity to assess someone, and doing that we have to be polite and gentle. So first we thank them, and then we say, okay, if time would have allowed, maybe they would have covered, but they missed. So then, yeah,
exactly.
Yes. So, but I think he got caught in the time. Yes, thank you so much. If time would have allowed, he would have covered all those. So my request, Dr. Saddam, when examiner asks you in exam, okay, can you summarize up your history taking? So first, remember, because you couldn't complete your history, you were still about with the presenting complaint. So remember all the other steps that you would have asked if time would have allowed you. So you can just quickly say, if time would have allowed me, I would have completed the remaining parts of the history, like past medical and surgical history, family history, social history, drug history, etc., etc. And then ICE, idea, concern, and expectation, and even the systemic review. And then you can say, okay, what your presentation was quickly. So my one question to yes, and here is your question. Right, so if you have read and understood, considering it's surgical and optimization, kindly tell me, what are you looking at?
Yes, ma'am, it's the skull bones showing left side of the skull with temporomandibular joint.
Yes.
The bones surrounding.
Yes.
So number one is the condyloid process of mandible. Number two is
yes.
coronoid process. 3 is the ramus of mandible. 4 is angle of mandible. 5 is body of mandible, and 6 is metal foramen.
What transmits through the metal foramen?
There are mental nerve and vessels or inferior alveolar nerve.
Okay. Can you tell me what type of joint is temporomandibular joint?
It's the synovial joint with
what?
With hinge movements of opening and closing the jaw, and lateral sliding movements, and also protrusion and intrusion.
Yes. What are the muscles which are responsible for opening the jaw?
Lateral pterygoid is responsible for opening the jaw. Associated muscles such as mylohyoid, other neck muscles, strap muscles.
Yes. These muscles are supplied by which nerve?
They are supplied by mandibular branch of trigeminal nerve.
Okay. All right. Can you tell me what are the structures which stabilizes temporomandibular joint?
Yes, ma'am. Temporomandibular joint is strengthened by three ligaments. Lateral sphenomandibular,
Yes.
stylomandibular and mandibular.
Yes. Okay. And in which position this joint or in which condition this joint becomes weakened?
Osteomyelitis of the joint, ma'am. I'm not sure. Sorry, I'll come back to this later.
All right. Can you please tell me what are the muscles which insert? I'll show you the position here. Which inserts here?
Yes, ma'am. A temporalis muscle.
Yes, please.
Yes, ma'am. A temporalis muscle inserts on the colloid process.
It originates here or it inserts here?
It inserts here, ma'am.
Okay.
Origin is from this. Yes, ma'am. Origin is from temporal, subtemporal fossa.
Yes. Okay. What are the innervation of this muscle?
This is also supplied by mandibular branch of trigeminal nerve.
Yes. What is the function of this muscle?
Yes, ma'am. It closes the mouth, and also it causes a retraction of the mandible.
Elevation reduction. Okay. Can you tell me this muscle along with which other muscles are considered as muscles of mastication?
Yes, ma'am. Medial and lateral pterygoids, temporalis, and masseter are considered as muscles of mastication.
Yes. Good. Okay. Can you tell me the course of the nerve which comes out from here? It goes where?
Yes, ma'am. The submental nerve or inferior alveolar nerve, also known as dental nerve, is a branch of mandibular nerve of the trigeminal nerve, third branch of trigeminal nerve, and it enters the mandible from the mandibular foramen inside the ramus of the mandible. And after traversing the course inside the mandible, it will come out of the mental foramen. And meanwhile, it will supply the meanwhile, it will supply the ipsilateral half of the lower teeth and the gum.
Can you tell me this temporomandibular joint is weakest at what point? If there's a fracture, or if a person like this one punches and a person has injury or damage of the joint, which is the weakest point or where is it?
Yes, ma'am. It's the body of mandible followed by angle and the condyloid process of the mandible. And afterwards, the symphysis of the mandible.
Okay. Is there a way we can classify the fractures of temporomandibular joint? Any classification criteria that you know of? Or what are the types of fractures that we have? Okay. Can you please tell me what are you looking at now here?
Yes, ma'am. It's the 3D reconstruction computerized tomogram of an adult skull shown from the right lateral.
Yes.
Showing right lateral side.
Yes.
And it is showing temporomandibular joint.
Yes. Can you please identify the structures labeled from A, B, and C and D, and then X, Y, and Z? What does it show, please?
Yes, ma'am. A is the condyloid process of mandible. B is coronoid process of mandible. C is ramus.
Yes.
D is angle of mandible.
Yes.
X is the squamous part of temporal bone. Y is zygomatic process, and Z is mastoid process.
Yes. Okay. What is the significance of doing this tomogram?
If any fractures are there due to injury to the skull
Why not
bone,
MRI?
it can be easily identified.
Okay.
Because on MRI, the bony lesions are not very well defined. The CT scan is specifically used to see any bony pathology or fractures.
Yes.
And also it's a case of trauma. So CT scan is the time required to perform a CT scan is much less as that compared to do MRI.
Good. Yeah, I'm looking for more questions. Right. Okay, meanwhile we're waiting, you can tell me the origin and insertion of masseter muscle, please.
Yes, ma'am. Masseter, it originates from inferior and medial border of zygomatic process, and it is inserted on the ramus and angle of mandible, outer surface.
Okay. Can you tell me what is the type of cartilage which lines the articulating surfaces of temporomandibular joint?
It's the hyaline cartilage.
Okay. And there is another question. Can you please tell me the type of cartilage and the cartilage is the intra-articular disc of the temporomandibular joint composed of?
Yes, ma'am. It's the fibrocartilaginous disc, which divides the joint cavity into upper and lower compartment, each containing different amount of synovial fluid, and each cavity being responsible for different type of movements.
Okay. If there is dislocation of uncomplicated, I must say, uncomplicated dislocation of temporomandibular joint, then in which direction this joint will be dislocated?
Most common type of dislocation is anterior dislocation.
Why? Do you think it would be anterior?
Yes, ma'am. Anterior inferior dislocation.
Yes. Okay. Anteriorly, not inferiorly. You were correct. But then you should have been confident enough to say yes. You were confident, but I confused you. Sorry. Good. And here is your question. Right, so if you have read and understood, considering the history taking station, kindly begin.
I'll enter the room. I'll wash my hands. I'll
Yes.
introduce myself. Hello, I'm Dr. Karma. I'm one of the exam candidates. May I confirm your name and age, please?
Yes, I'm John. I'm 56 years old.
Hello, John. Nice to meet you. So today I've been asked to talk to you and ask you a few questions about your condition and also some personal questions. I'm here to help you. So whatever you tell me will be confidential. Is it okay with you?
Okay, doctor.
Okay. I'll ask
Chaperone?
for chaperone.
Yes.
Yes.
Good.
And then, so how can I help you today?
So, doctor, actually, I came with this some problem in my personal life. I'm not able to like there is difficulty for doing the physical activity. It's causing me really stressed out.
I'm so sorry to hear that. Can you tell me more about it? Like, do you have like a difficulty obtaining an erection?
Yes, doctor.
Yes. So when did you first notice it?
I noticed it around a month ago.
Okay, and how has it been progressing over the time?
Yes, doctor, it's becoming worse.
I understand it's difficult for you. So did you notice anything that improves it or that makes it worse?
No, doctor, there is nothing which improves it or makes it worse.
Okay. And did it start suddenly or gradually?
It was gradual, doctor.
Okay. And you said you have difficulty obtaining erection. So is the erection suitable for penetration?
No, doctor.
No. And can the penetration be maintained until your partner gains orgasm?
No, doctor. I'm not able to penetrate.
Oh, I'm sorry. It must be difficult for you. Does ejaculation occur?
No, doctor.
No. Okay. Uh, is there any pain or discomfort associated with that?
No, doctor.
No. Any problem with your penile curvature?
No.
No. Okay. I would like to ask a few more questions. How about your sleep? Do you have difficulty with your sleep?
Oh, no, I'm not having any difficulty to
Okay.
get sleep.
And how about your appetite?
Yes, it's normal.
Okay. And have you been feeling low recently or depressed, overly tired?
No, I'm not depressed, but I'm really stressed out due to some problem in my work.
Oh, okay. Uh, uh, I'm sorry to hear that. So, how about your libido? Any change in your libido?
No.
No. So you said you have stress related to work. Any stress related to other social issues or family pressure?
Yes, I also have some family pressure regarding other personal issues of property. So,
Okay, sorry to know that. Any anxiety related to performance or your sexual relationship?
no, doctor.
Uh, I would like to ask you some personal questions, if that's okay with you.
Yes,
Uh,
doctor.
are you married?
Yes.
And okay, and when was your last sexual contact, if you remember?
Yes, it was more than 1 month back.
Okay. Have you had any sexual contact other than with your wife?
No.
Okay. And did you have any medical conditions that you know?
No.
No. No history of hypertension or diabetes or thyroid problem? Nothing.
No. No, doctor.
Any medication that you're taking for anything?
No.
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 Any history of surgery in the past?
No.
No. And what do you do for living?
I'm an entrepreneur.
Okay. And who do you live with?
I live with my family, my wife and kids.
And does anyone in your family has similar kind of condition?
No, doctor.
No. Do you smoke or drink?
Yes, I do smoke a cigarette.
How many sticks or packs?
I smoke 8 to 10 per day.
8 to 10 sticks per day. Okay. And how long have you been smoking?
Almost for 10 years.
10 years. And no alcohol?
No.
Okay. So You have come with this condition. What do you think would have caused this to you, and what are your major concerns?
So, doctor, I think that I'm suffering from some disease, and I'm really concerned that why this is happening with me. What is the cause? Is it very anything serious?
I can understand your condition. I can understand your situation, concern. We will get back to this, get to the bottom of this together, and then we'll try to complete the history and investigations, and then get back to this together. Thank you for your time.
Thank you.
So if time would have permitted, I would like to complete the expectation and the systemic review.
Yes.
I've taken history from a 56-year-old male,
yes.
Who is the father of two, who has a history of difficulty with erections, and he also has a history of stress related to his work, and he has been having that since 1 month, and it has been progressive and getting worse over the days. And he also has stress related to work and has also his family issues. And he has no other medical condition or history of surgery or on any other medications. He is a smoker, smokes 10 sticks per day for 10 years. From my
so what are your
history,
differential diagnosis for this patient?
I would like to consider this erectile dysfunction, possibly due to psychological causes. I would also like to consider atherosclerotic vascular disease, since he is a smoker. And I would also like to consider drug-induced, though he has no history of drug intake.
How would you confirm your diagnosis? What are the investigations?
To confirm my diagnosis, I would like to do some investigations. First of all, some blood investigations like full blood count, ESR. I would like to rule out any history of any diabetes by doing blood sugar, glycosylated hemoglobin. I would like to rule out lipid profile, urea electrolytes, do some hormonal assays like serum-free testosterone, prolactin, FSH, LH, imaging like duplex ultrasound, transrectal ultrasonography.
What are the treatment options that you can offer to this patient?
I would like to do risk factor modification if there is any, like control diabetes, hypertension, control his lipids, and weight loss, smoking cessation in this case. And for drugs, I would like to start around phosphodiesterase 5 inhibitor like sildenafil, and I can also give him intracaverous injection of alpostatil.
Yes.
And if that doesn't improve, then go for penile prosthesis.
Yes. Okay.
Yes, I
gave you 1 minute extra because
I forgot one important question.
Yes.
The morning and nocturnal erection.
Very good. Yes, nocturnal. So, Dr. Snell, can you please give feedback first?
Yes, ma'am. It was, ma'am, very sensible and very perfect history.
Yes, yes.
It was very perfect one. Like almost he covered everything.
Everything, yes.
Yes, ma'am. Only one issue, ma'am. I think he should have asked about, do you have any kids? Like that, I told him.
One more, okay. With this, because in the history I've not written that patient was married to opposite gender, could have been married to the same gender as well. Children, people have surrogates children, doesn't matter. It doesn't signify, it doesn't tell you that person is, they become biological parents themselves, but then they have it surrogates, someone else gives birth to their children. So could even be the male partner. So you here, okay, you once asked, so you said, I live with my wife. It could have even be boyfriend, or could have even be husband, or could have both be of the same gender, like, I don't know. So that is one thing. And I think he asked you if there was any other extramarital contact?
Yes, ma'am.
Yes, I asked, ma'am.
Yeah, that's wisely to ask. Yes.
Hello.
Yes, please.
Yeah, ma'am. Sorry to interrupt. We can simply ask about sexual orientation.
Yes.
Yeah.
Because chaperone was there, but politely in a respectful way. Like what I noticed, Dr. Karma was respectful. So in this polite, respectful way, you can say, okay, is that all right if I can ask you, what is your, how do you classify yourself, or how do you describe yourself? What is your sexual orientation? So politely, yes. Someone else was also trying to say something. Was it Dr. Karma or anyone else?
Yes, me, ma'am.
Yes, please.
The question I have is like regarding the sexual history, the marital status, like you were mentioning about the gender. How do we ask that? Like, he could be married to a male also, like
just
you
like
mentioned.
this, who do you live with? You asked, okay, the person tells you, or there could be even like separation, but then you asked, okay, if you don't mind, can I ask you what is your sexual orientation? How do you describe yourself? How do you identify yourself? Not describe, identify. These are very sensitive questions. One has to really prepare themselves very nicely and in a very respectful way to ask them, because these people are extra sensitive and they feel a lot. They feel it.
Okay.
So one has to be, yes.
And regarding the medical history, surgical history, any medication and systemic review, there's a long list.
Yes.
So is it okay, like how I asked, any history of do I have to mention specifically, or like I mentioned, like
yes,
any history of medical condition,
yes.
any surgery?
Yes. So you have to be specific and ask, is there any condition for which you are seeing your GP, like diabetes, blood pressure? So you have to be specific and give examples what you think if patient, because here I think patient is hypertensive and taking already atenolol or something. So here you have to keep this in your mind and you have to ask, is there, and the best way is to ask like this, that is there any medical condition for which you are seeing your GP? Because normally in West, all the patients or all the 50 plus or some, these sort of, they are registered to a GP. So there is already in a GP who's taking care of these patients already. So even if they have flu or sore throat or something, so they go to GP first and then GP sends letters and sends them to.
Because here, like if we try to list the surgery or medical condition,
that will take too time. Or you can simply ask, has there any been condition for which you were operated? So simply you ask that. And one question, Dr. Karma, you use the word orgasm. Is it layman term or is it a medical term?
I think orgasm is layman term.
They understand, but sexual satisfaction shouldn't be the more appropriate term or word to use. I don't know. Others can also comment.
Orgasm is, I think, layman term, ma'am.
Yes, you can say that, but then I was thinking that reaching orgasm is not always important. Then is achieving or acquiring the satisfaction anyway.
Okay.
Yeah, good. Okay, thanks.
Thank you.